So, Dr. Khan, thank you so much for taking the time and joining me on the Inductive Economy. It's an absolute honor and a privilege that you've chosen to spend your time with me. So, thank you so much.
Really happy to be here and thank you for the invitation.
Thank you, ma'am. So, Dr. Khan, you graduated with an MBBS and you have an MD in microbiology. What inspired you to pursue a journey in clinical research versus opting for a traditional practice of medicine? That's my first question.
Well, actually, I started out by doing what clinical microbiologists are supposed to do, which is to stick to the lab. I did branch out a little bit in beginning to do more experimental lab medicine. But then I found that that really wasn't the kind of area that I wanted to be in. So if you think about lab medicine in India and lab medicine in the West, at the time that I started, any basic science question or applied science question that I chose to pursue, which required working, for example, with cell lines or animal models, I knew that that could be done much faster in the West. This was still in an era where if you ordered reagents, they would take 6 to 9 months to come. You were spending a lot of time waiting for things to happen. Plus, I thought, not only is it going to be slow, take a long time, am I not going to be able to do the deep dives that are possible in better equipped laboratories elsewhere? But this wasn't really addressing the problems that I wanted to address, which is what is the cause of disease in India and what can we do about it? So I started to work very quickly in communities. I started first by looking at outbreaks of disease, and then that went on to looking at interventions, then thinking about, children, gut damage, all the things that happen when you live in challenging circumstances. So yeah, it was a kind of progressive switch moving out of the lab and pretty much into public health.
Yes, ma'am. And along this journey, who were some of your key mentors or influences during those early stages of your career? And how did they shape your approach to medical research?
So I think one of the things that is important to understand in medical research, especially when you think about research in the context of a medical college, there is very little incentive to have a very focused research career. There is a requirement to guide students for their dissertation. So, in your MD, you're expected to produce a dissertation. And for that, usually you will have a professor in the department to guide you. But there is so much material that you can investigate from your routine work, whether that is clinical work or surgery or in the lab, that it doesn't require you to step very far out of your comfort zone to produce a paper or two. Given that the requirement for publications within academic medicine in India today is so small, you need 8 papers to become a professor, that there isn't incentive for anyone to do very much more because you have a large workload. Why would you want to add to it? I was really lucky that I made an early decision that I didn't want to stay in clinical microbiology, and I moved into a department that was an integrated department where we had clinical gastroenterologists, clinical hepatologists, pathology, microbiology, physiology, all focused on the gut. So that interdisciplinary exposure that I got at CMC has really shaped my thinking, and it's very rare to find that in other places. Many institutions now are looking at, let's say, the Institute for Liver and Biliary Sciences or the Center for Neuroscience. These are all established in order to bring different disciplines together, and I think if you want to produce high quality research, you do need now a multidisciplinary, multi skilled kind of approach that I had starting out 30 plus years ago. So I think in terms of the Wellcome Trust, which funded the department that I was in, the clinicians, the scientists that built that department in the 60s, 70s, and 80s, when I came around in the 90s, there was a platform to work from and to work with. So that was inspirational in itself, to have a legacy and then to be able to follow along in interdisciplinary research, but making my own direction within that space. Then I had the
Yes, ma'am.
opportunity to do some training in the UK and the US. And there also I found people who kind of thought that I was good at what I was doing. And that can be a very powerful motivation to try to do even better. So I came back to India, and that's pretty much what I've done.
Absolutely. In fact, my follow-up to that is, can you talk about your postdoctoral experience research work with, Dr. Mary K. Estes, if that's all right. I hope I'm getting her name right.
Oh,
And,
Mary has been a absolutely stellar mentor, continues to be a mentor even now. So at the time that I went to join her, she told me I don't take people for a 1 year period, which was the time that I wanted to spend with her. So I spoke to her for a little while. I said, I'll work my guts out, but I really can't stay longer than a year. And if it is required, I'll see how much of the work I can continue once I'm back in India. So she did take me on. She sat down, and the first thing we started with is, what research question will you address? And that research question that we defined was, the hypothesis is A will result in B, right? And we've spent a long time testing that hypothesis. We built on those studies. 20 years later, I'm still working on the same problem. So, Mary has an incredible ability to identify key questions in the field that we work in, which is viral gastroenteritis. She is a basic scientist who sees clinical applications and is, very willing to support people to pursue directions that they think are interesting. And unusually, she's always taken on the responsibility of providing resources to young people so that they can pursue the direction that they want. So she's tough, she's had to be, but she's also been incredibly empowering.
yes, ma'am. And I think interestingly, she was also involved with the very early work on rotavirus, if I am not mistaken. And she was coming on, which
Yeah, her
I found
entire
that.
career has been,
Yeah,
yeah.
right. So I found that super interesting that, you work with somebody who's so into understanding the rotavirus, and then when you come back home, that's the first, at least in my understanding, the first big pillar of your stellar career, which is learning from the best on what is the structural understanding of the rotavirus, and then coming back home to see how we can actually solve it at scale. So, can you talk a little bit about, you know, I don't know whether fortune is the right word, but learning the principles to actually leverage that. What do you think of that?
So actually, the work on rotavirus in India started in my department in the 1970s. So prior to my going to work with Mary, I had been working in bacteriology, but I had been assisting another scientist to work on virology, including rotavirus. So when I trained in the UK, I decided that rota was something that was worth pursuing and did a study. So I had some rotavirus foundation before I went to Mary's lab. What was different about working with Mary was moving from the purely epidemiology, clinical microbiology focus to actually thinking about the basic biology of the virus and then using that information to try and inform our clinical studies. So Mary does a lot of basic virology. She works
Mm.
with a structural virologist, Dr. Prasad, also at Baylor. So they have done some of the absolutely fundamental structural studies on many of the rotavirus proteins. And some of those studies have informed our understanding of how rotavirus infects cells, how it replicates, which are the proteins that are important at different stages of entry and replication of the virus. So understanding that allows us to think about where can you put an intervention? What can you actually try to fix and what is not going to be an achievable target?
Understood, ma'am. And coming to the rotavirus part, I was while preparing for this conversation, I went through the TED talk that you gave at AIMS Bhubaneswar, and you relayed the story of Altaf and Najma, and there was a phrase that you particularly used. There was a phrase that you used, which is clinical research is not something that you do to people; it is something that you do with people. And I felt like I understood what that statement meant, but when I heard the context of the story. But can you elaborate it for our listeners, as in what do you mean by that statement, that clinical research is not something that you do to people, it is something that you do with people?
So, if you think about it, when you start off in medical research, you think you know what the problems are, and you also have a reasonable idea of the solutions, and you think that if you can test the solution appropriately in an experimental system, then you will have an answer. It works. So, you know, that's what clinical trials are about. You think you're going to be able to come up with a product, a strategy, a treatment that is going to benefit people. It's a very, very top down approach. I think I know what the problem is. I think I know what the solution is. But when you begin to work with people, and particularly people in communities, you realize that sometimes what you think is a huge problem is not a problem that they ascribe the same importance to. Something that bothers them may be very different from what your conceptualization is. So, really trying to understand from people what their issues are, what their problems are, helps us in identifying what we should work on as a problem to be solved. And it also helps us in thinking about the approach with which we should be addressing that problem. So, if you think about vaccines, for example, I might think that there are 10 causes of diarrheal disease, so therefore there must be 10 vaccines for diarrhea. It may be that the community doesn't think that solving every diarrheal disease is an issue. You solve the main two, and then after that, they would like to see a solution for pneumonia, a solution for fever, a solution, for cancer, for something else. How do you decide your priorities? What do you decide to do? I think needs to be a decision that is made jointly by the community for whom you are trying to come up with solutions, and the researchers that are trying to work on those solutions. So I think respect for the community is what it's about. People, well, people are guinea pigs in in this approach of evaluating any new treatment. There have to be experimental systems. Without those experimental systems, without those clinical trials, there will be no new treatments tomorrow. So, when you decide that you want to be able to test for an intervention, I think it's only the right thing to do to respect people's choices and to take them along with you so that whatever intervention you evaluate has value for them as well as for the broader medical community. Otherwise, it just doesn't make sense to do research in India.
Absolutely, ma'am. And I think there was another part in that same speech where you were basically saying that, there was a public perception study that was run by St. John's. And,
Yes.
can you, on the public perception of clinical research, and maybe specific, because it, like you can understand, it ties back to the original thing that you were saying. Can you talk a little bit about the outcome of that study? And, why is it so critical that trust is such an important factor when you're trying to solve these sort of problems in a country, especially that is extremely tight knit in terms of its community, like India?
Yeah. So, St. John's did that study because there's an area that we have been exploring, which is called controlled human infection models. And the idea back then was that St. John's would conduct a public perception study to understand what people think about clinical research and the directions in which clinical research might go. Now, one of the problems that happens in infectious diseases is that we rely very heavily on animal models. Now, the problem with animal models is that animals are not humans. And therefore, when you decide that you want to create a human disease in an animal model, it only has value when the disease in animals mimics the human disease. And quite frankly, there are very few diseases for which there is a good animal model. So you could argue from an ethical point of view that we are not doing the right thing by animals by experimenting on them for something that might have very little value to them and little value to humans. If you have to solve a human problem, ultimately it will wind up being a question of human biology. So, in order to understand more about infectious diseases in humans, there has been this approach of looking at, can you deliberately infect people? This has been done. This has very serious ethical issues because we all remember what happened in the Second World War, where you had prisoners, incarcerated people being used for all kinds of really gruesome experimentation. Some of that included infectious diseases, some of that included surgical procedures, chemicals, all kinds of things done on people without their consent. This is what led to a lot of the revision of medical ethics. But since then, there has been an understanding that there is a lot that you can learn from doing studies very safely in humans. So, controlled human infection models deliberately induce an infection by choosing a strain that is not going to cause severe disease in humans, thinking about, if anyone does develop disease, is there a rescue strategy? Now, my problem with many of these controlled human infection models is that when you take, for example, a disease like typhoid, and you put the controlled human infection model in Oxford, right? Typhoid is not a disease of the UK anymore. It has not been for the last century plus. But it is a disease of India, of Bangladesh, of Pakistan. So, if we want to study the disease and the vaccines that might control the disease, is Oxford the place to be doing this? Now, some ethicists in India argue that, it's fine, we are guinea pigs for the West, so let the West be guinea pigs for us. Well, that is one point of view. Only if you can tell me that the biology of people who have no prior exposure to typhoid, no prior exposure to other infections, is exactly like that of people in India. So, essentially, you're creating another model with potentially little value for the people that actually have the disease. So, in the discussions that we had with St. John's, with ethicists, we came to, it's not about controlled human infection models themselves being a form of experimentation, because all controlled human infection models are one kind of clinical research, right? So we did a study to look at perceptions of clinical research and then had some questions about controlled human infection models. What came out from that study very clearly was that in India, people have very little trust in medical researchers. They have a feeling that they are being experimented on, that nobody tells them exactly what to expect. And this is something that was encountered as a problem in 2012, 2013, when the Supreme Court actually stopped all clinical trials in India, saying that there was no need for anyone to do clinical research in India, especially not drug companies, because Indians were being used as guinea pigs. My argument is, if we want better medicine for India, for people who grow up, live in India, we have to experiment on people. How do you do that safely, ethically, knowing that the benefits are going to outweigh the risks? How do you get people to partner with you in that research? Maybe I'm an optimist, but I think it can be done, because this is exactly what we did with the communities that we have worked with. Over the 20 years, we've built trust. We've shown we are there for the betterment of the community, not to experiment on them and then walk away taking whatever advantages of learning or anything else that we have. And I think if you really want for clinical research to happen in India, you have to build that openness, that transparency, make the time for patients to understand, to discuss, and constantly communicate with them why you're doing what you're doing. And anytime any participant in a study wants to walk away, it's become too inconvenient for them, absolutely they are free to do that. And you have to make sure that there is absolutely no impact on their further clinical care. So, clinical research in India is a fraught topic, but I think if there are certain basic principles which are the really boils down to respecting people, we can create the environment where we can do ethical, high quality clinical research for Indians to solve our problems.
I think first of all, thank you so much. That was an incredible answer. It touched on so many follow-up questions that I have. Uh, I think the one that I really want to go back to is the ethicist sort of an argument. And one thing that I noticed was that when the Rotovac had come out, it was a known side effect that it would cause interception, right? And but the odds of it were 1 in 20,000, and the odds of it actually appearing in your preclinical trials had was zero. It had not come up. It was a known side effect, but it had not come up. But you know, it's. Do you think that we tend to see statistical anomalies much too grimly in India, and without considering other factors like alternatives, and we go straight down to accusing researchers of unethical behavior or other kinds of malice? And it's a very honest question. I'm just
No,
asking because
completely get where you're coming from, because, one of the things that people don't understand, especially lay people, is that no drug, no vaccine is 100% safe, right? If you drink too much water, you can cause significant damage. You take too much paracetamol, you can damage your liver. So there really is no drug, no vaccine that you can say is 100% safe. Now, when you're doing a trial, a clinical trial, the one thing you want to measure in every phase of clinical testing is safety. Your phase 1 study is a safety study, small number of people dosed so that if there is anything significant or serious, you can identify it. In phase 2, again, you're looking at safety first. In phase 3, where you're looking for a clinical effect, still you are looking for safety. Because, if you think about what the duties of a regulator are, they are to ensure that whatever is manufactured is of high quality, whatever is manufactured is safe for people, and whatever is manufactured is effective. So if it makes a claim, that claim must be true. So that's why monitoring safety in clinical trials is really important. Now, in India, we follow the same regulatory system as everywhere else in the world. But if you look at people who are looking at, ethical questions, just like in the clinical trials I told you about, or, other studies that have happened in the past, people tend to look for bad news, and it can sometimes be easy to think about a potential risk. So, in the case of the rotavirus vaccines, the very first rotavirus vaccine, that was Rotashield, was evaluated in a little over 10,000 children in the US. They saw a couple of cases of interception. They discounted it because it was equal in vaccine and placebo recipients. And then they went ahead and licensed the vaccine. They gave out 1.5 million doses of vaccine and then noticed a signal of intussusception in children who had received the vaccine. Now, intussusception is a common pediatric emergency. It happens in the absence of vaccination. It's the commonest pediatric emergency in children, surgical emergency in children approximately 1 year of age. 6 months to 18 months is when it normally happens. Now, you give a vaccine at, in the US, 2, 4, and 6 months, you allowed a catch up dose. They started to see intussusception in the first week after the first dose. So, a common event, but occurring in association with the timing of vaccination. So, you know that when, I've given a drug and I get a headache, I will associate the
It's
headache with the
causal.
drug. It, there is likely to be a causal relationship.
Likely causal. Yeah.
Yeah. So they studied it and they found that there was an association. It was rare, but it was there. So that vaccine was withdrawn. So then they designed studies to look at new rotavirus vaccines, and the new studies were designed to detect a risk of intersusception that was like the intersusception that had been seen with the Rotashield vaccine. This meant they did studies of 60,000, 70,000 children in order to find a risk of intersusception. They did not find a risk of intersusception in those 60,000, 70,000 infant studies. Those two vaccines were licensed in 2006 and started to be used in high income countries around the world. Once those vaccines had gone from being in tens of thousands of children to hundreds of thousands of children, you started to see a risk of intersusception. That's how rare it was,
Yep.
right? You couldn't find it in 30,000 vaccinated kids, 35,000 vaccinated kids. But once you got to hundreds of thousands and millions of children getting vaccinated, you saw a risk. That risk varied between 1 in 20,000 and 1 in 60,000 vaccinated children in the studies that were coming from the West. When Rotavac was to be evaluated in India, the decision was made to look only for efficacy. We would still be monitoring for safety, but the size of the study was enough to look at efficacy, not enough to look at interception. So basically, if the risk of interception is 1 in 20,000 children, how many children do you need to be able to study to be
Yeah.
able to get an answer about how big the risk is? It would have been hundreds of thousands of children needing to be in the trial itself. So the trial was designed only for efficacy. 6,800 children, two-thirds of whom got vaccine, one-third got placebo. So two-thirds vaccinated meant little over 4,000 children that got the vaccine. So the risk is 1 in 20,000 maximum. You're studying only 4,500, 4,800 children. Anyway, so we did the study, but we said we will monitor very carefully for interception. This meant that we would not monitor only the first week after the first dose, or the first month after the first dose, or the first month after first, second, third dose. We said we will monitor all the children for the full 2 years of follow-up. Not only will we not monitor them the way other studies did, which is when you have a child that complains, that has a surgical emergency, we will find that child. Here, any child that vomits more than 3 times in 1 hour, we will do an ultrasound. Any
Right.
child that has blood in stool, we will do an ultrasound. Any child that has, the mother says, has abdominal distension, we will do an ultrasound. Okay? So, and we will do it within 8 hours of the child complaining. So it
Right.
was the most incredible study. We had, we did about, in Velo, we had 1,500 children, we did 580 ultrasounds. And it
Amazing.
was actually kind of funny because we found interception, because interception is diagnosed on ultrasound. And then our pediatric surgeons, whom we had recruited into the study, told us, you know, the children that you are bringing from your trial are not like other children.
Oh.
So we said, what's the difference? So they said, you know, your children have very mild symptoms. So initially, when we started the study, the standard practice for interception is first you do an enema, and that
Hmm.
enema is usually enough to fix the interception. You can do
Right.
an enema with air or an enema with water. So we would bring a child in, get the ultrasound done. Pediatric surgeon will do an enema and say, okay, kid is fine. And then they said, you know, your kids aren't like our kids. We think we are just going to wait and watch and see what happens. So they started waiting and watching, and they found that all the interceptions started going away by themselves. So it was our monitoring, a very, very close monitoring, that was creating this perception that there were lots of interceptions happening. And actually, it was when you, and later the pediatric surgeons told us that when they do open abdominal surgeries on children, they can see an interception happening and then it comes out by itself. So this was something that we were picking up incidentally on ultrasound, most of which would resolve them with themselves and not become the typical clinical picture of interception. So now in safety monitoring, when I talk about vaccine trials, I use this as a story of where sometimes, because you set yourself up to do everything very carefully, make sure that children are perfectly okay, that you create problems. So in any case, what happens generally if you have an interception that comes to hospital, in usually the enema fixes it, and the percentage of children that need surgery depends on how late they have come. In the south in general, in Kerala and Tamil Nadu, where we have studied intussusceptions, maybe 1 in 5, 1 in 10 children, 1 in 20 children might require surgery. In the north, it tends to be almost 50% of children need surgery because they come late. In our study, which was done in Vellore, Pune, and Delhi, not one child required surgery. Everybody resolved with just the enema. And as I said, in many cases, even that enema was unnecessary. So, this, of course, got picked up, and people who monitor clinical trials, especially of vaccines, and are always looking for safety signals, brought it up as an issue. We published all the data that we had. We had no cases of intersusception that were anywhere in the risk windows of, even with our very generous definition, there were no cases of intersusception after any dose of vaccine. The first case was 35 days after the third dose and was in a child that received placebo, not vaccine. But
Right.
it became a story.
Yeah. No, no, those cases are the inconvenient ones that nobody picks up, because the study doesn't tell you whether somebody is on a placebo or not, right? It's only
Mhm.
afterwards you find out whether they've been on placebo. Till that time, everybody assumes that
Exactly.
they're all on the. That's the design of the experiment. But the problem is that, because you have. This is a really interesting illustration, if I had to use it as a vignette for something, that the level of statistical education in India is actually quite high, but their understanding of how medicine and how medical research works is actually very, very low. So they see 1 in 20K, then they get down, they get their Excel spreadsheets out, they crunch the numbers. They're able to say that, hey, this is the correlation, this is the causation for it, this is not clear. I'm actually, sometimes, I don't know, what do you think, but if they saw the original numbers for the Salk vaccine, I think they would be horrified if they saw while the vaccine was absolutely effective, it does come with cost, right?
Absolutely. As I said, with any product, you have to look at risk and benefit, and the benefit has to far outweigh the risk. That's especially true for vaccines because vaccines are given to healthy people in the tens of thousands, hundreds of thousands, millions. So you will have some very, very rare events that occur. The oral polio vaccine now, you have many cases of vaccine associated paralytic poliomyelitis.
Yeah,
So there are safety issues with vaccines that we have to monitor and have to be concerned with. It would be fantastic if we could make 100% safe vaccine, but some of the ill effects of vaccination are actually down to the host response. And
right.
it's very unpredictable which host is going to respond in which way.
Which
For
way?
example, in the US, where they have seen that, in rotavirus vaccination rarely is associated with intersusception, there is no increase in the overall intersusception rates in the US after the introduction of the vaccine. So then the question comes up, would these children have had intersusception anyway, but the vaccine made them have it earlier?
Yep.
So those are questions that can only be answered with very, very large studies with very, very good data. And
Yep.
unfortunately, in India, our data outside of a clinical research setting tends to be quite variable.
Right. And it just ties to my next question, and I think you also touched upon it, which is, you also had a phrase in that specific talk where you said that innovation comes with risk. There's no such thing as risk-free innovation. And being in, and like you touched upon, being in clinical research, being in vaccine development, can you break down what innovation means to you, and how do you really balance it out in this risk-reward framework that you actually spoke of?
So, if we think about innovation, there are many ways. You can have innovation in delivery and you can have innovation in product. So, at that time, I was discussing innovation in products, new technologies, new products. What is it that it takes for us to solve a problem? And our understanding of biology has expanded so much over the last couple of decades that we now have tools available to us that we never had before. But with new technologies come new and unknown risks. So, for example, if we look at vaccines, we've had vaccines for over 200 years. But for the first, I'd say, 150 years, the technology was very simple. Either you have the whole organism and you kill it, or you have the whole organism and you weaken it, or you take a part of the organism. That's it. The three technologies for making vaccines. Now you have mRNA, you have DNA vaccines, you have a lot of different ways of delivering a product, right? What are the risks associated with that? What are the short term risks? Those we can measure when we use that product in enough populations and monitor them well enough. What are the long term risks? We really don't know. Fortunately for us, vaccines tend to be one and done, right? Or two or three and done. So, most of the risks that you will encounter, you will see in a relatively short time frame. That is not the case for drugs, for example. So, a drug can be given repeatedly to the same person. In trials, you will measure a short term risk. In trials, it's very difficult to measure a long term risk. What happens after 5, 10, 15 years of using a product that was evaluated in a clinical trial for 3 months or 6 months? So I think thinking about technologies and thinking about what the potential risks might be and how we monitor those risks becomes really important. And regulators now are familiar with these approaches and require that kind of safety surveillance to be continued. So, as we think about the future of innovation as well, we have to be thinking not only about potential benefit, about efficacy, but also thinking about what risks are we willing to accept. And
Right.
that's a challenge.
Absolutely. Because it's a judgment call at the end of the day, right? It's you can get as much of data as you want. You can parse it, you can slice and dice it however you want. You can put it through the most rigorous of checks and balances from a regulatory framework perspective. But at the end of the day, whether the intention to whether to test it out or not still remains a judgment call, right?
I think, yeah, in testing it, again, there is testing knowing what the risks are, and there's testing when you have unknowns.
Yeah.
Yeah. So they're designing studies so
Mm.
that you can pick up early signals of risk becomes
Right.
very important.
Yeah.
And that's part of pharmacovigilance. And
Mm.
pharmacovigilance has to really step up to keep pace with emerging technologies.
Understood. I want to move to the next portion of our conversation, and it's on COVID-19. And upfront, it's not going to be any political stuff. It's not going to be about vaccine denying or any other such madness that people generally deal with. We understand the risks. We have been discussing the risk of it for the last 20, 30 minutes as part of this conversation. But I want to ask a few relatively open ended questions and get your feel on the entire experience. Because rather than digging, I think there are many people who dug into the specifics of it. But as somebody who's been at the forefront, what was the all encompassing experience for you? That is something I want to understand as part of our conversation. I hope that is perfectly all right. So,
Sure.
just going forward, how do you compare the challenges in researching COVID-19 with your experience in rotavirus research?
So I have to say that, when the pandemic started, I thought that because I had worked on enteric infections for pretty much my whole career, that I was not the expert to comment on a respiratory virus. And then I realized that actually, as a virologist and a virologist dealing with mucosal infections, I probably had a much better understanding of what it was going to be like, what transmission meant, what intervention strategies might be appropriate. And I thought it was important to try and communicate at least what was my state of understanding during the pandemic. I was also at that time at the Translational Health Science and Technology Institute, and I had been on the board of the Coalition for Epidemic Preparedness Innovations, something that the Department of Biotechnology had gotten me involved with. So, a lot of the work that I had done at THSTI turned out to be perfectly suited to pivoting to address the questions that were being raised by the pandemic. So, THSTI and colleagues there were very experienced in running cohorts. They established the first infection cohort in the country and still one of the largest with the longest follow up. The laboratory was ready to pivot to testing, to looking at making standards, looking at diagnostics, the evaluations of vaccines. The BSL-3 was available to be able to set up for the assays that needed to be done. So it was great to realize that what we had been doing to prepare for vaccine evaluation was actually very useful for this particular virus. Now, it could have been that the pandemic could have been due to a virus that wasn't so amenable to a vaccine, wasn't so amenable to establishment of an easy diagnostic test. And that might have been more of a challenge, but it turned out that if we had to have a pandemic, as bad as it was, it could have been much worse. And I think the fact that understanding that a virus that has a very, very low case fatality rate meant that there were quite appropriate prevention strategies even before the advent of a vaccine was something that gave me reassurance, and I hope that I was able to convey that at least to some people.
Absolutely. And there was a lot of very interesting interconnected system of services that ensured that we were able to give out all the shots that we were able to give out in India. How significant was the role of technology in India's response to COVID-19, particularly in the areas of research and vaccine development?
So, I think the first thing, let's take the two vaccines that covered most of our population first.
Hmm.
Covishield was actually developed at the University of Oxford
Yeah,
and was made by Serum Institute of India, which is an incredible vaccine manufacturer.
yeah,
Covaxin was based on an Indian strain and was an inactivated vaccine made by Bharat Biotech. And they have a lot of experience of making inactivated vaccines before. They had made the JE vaccine following a very similar kind of approach. So those two vaccines were not key technology new developments in that
yeah,
sense, right? But in terms of the delivery of those two vaccines, the fact that India was able to get up COVID was, I think, quite remarkable. And pivoting the immunization infrastructure, setting up to do adult immunization for the very first time at this scale was a phenomenal exercise. And to be able to deliver glitches, you can question the quality of the data, you can question how the processes worked, at least initially, but the problems got ironed out, and a significant proportion of the population was vaccinated. So I think those were really key things, and those were built on existing platforms, existing manufacture, existing experience in the vaccine companies, a phenomenal vaccination program that India already has that was digitally enabled through EWIN previously. Tracking vaccines is not simple, and India had established the electronic vaccine information network previously, and that could be adapted to COVID, could be used to deliver vaccines. Just
I,
goes to show what we have the potential to do once we have the political will, the commitment of the bureaucracy, and the resources to go with it.
the wild thing about that is, I mean, maybe you may call me a cynic or something. I think it's not even a problem of political will or any or the bureaucracy or anything. It took a worldwide panic for our bureaucracy and for the government to step up. And within that, accelerated time period, you were able to push through it and, really get a solution out that could actually do something safe and scalable at population scale, right? I agree that it part and parcel is about political will, but the thing is that you cannot keep waiting for every pandemic to really flex your muscles. You need to have the infrastructure in place so you're prepared for it. It can't be post hoc preparedness, right? And I think every reaction, I mean, every solution cannot be reactionary. Am I making sense? Hopefully.
So, what you're referring to is solving problems in an emergency versus raising the overall standard
Yeah. Yeah.
so that you have a base from which you can operate very quickly. And I think one of the issues is if you do something well, do you become complacent and think the next problem that comes along we'll be able to solve it? Or
Right.
do you think, can we do even better, even faster if we have better infrastructure? I think we have enough infectious disease problems that persist in the country, as well as a rising tide of non communicable diseases, that speaks to the fact that we do need to improve our primary care, and that enhanced primary care base can be a way of being able to solve future problems quicker. So,
Understood.
while new technologies, new products can be very appealing, you know, you can argue that this is really true innovation. I think there is also innovation that can be done essentially in making sure that every person in the country is reached by the services that they need. And I hope that's the direction of travel for healthcare in India.
Absolutely. And in fact, I think COVID might have been one of those real watershed moments for a large swath of young people in the country, those who are, let's say that they are in high school when it happened, and they saw the impact, they saw the chaos it created, and they saw a response and a really successful emergence out of that chaos to a certain, there was collateral damage, but there was a very successful exit from the COVID era. So as a follow up, what advice would you give young researchers or aspirants looking to study, epidemiology or virology, especially post COVID-19?
I think one of the things that we realized during COVID 19 was that science brought us solutions. Without that science, we wouldn't have had the solutions. Whether that is genomics for tracking the virus, being able to identify variants. The fact that in Africa they could identify a new variant so quickly, both for beta and for Omicron, and then communicate that to the rest of the world. I thought that was an exemplar of what prepared scientists can do. If we look at the vaccine technologies, we delivered in 10 months. Now there is a new mission which is 100 days. Can you come up with a vaccine solution when you identify a pathogen in less than 4 months? Based on biology, it is something that is potentially feasible to do. But what all of this requires is for many areas of expertise to come together. When you look at genomics, the genomics informs the structural biology informs vaccine design, which informs the research that needs to be done, which informs public health practice, policymakers that decide on what vaccination strategies should be followed, data scientists that look at what's happening to the disease, what the impact of vaccination is. All of us really need to be working together in order to make this happen. It is not possible anymore for one person to have all the expertise to cover every aspect of a response strategy. So, if I think about young people, the opportunities to be able to contribute are incredible. And what it requires is to build your skills so that you are ready to contribute when there is an emergency. But whatever you learn can also be applied to many things that are a problem today.
Understood. Understood. You know, I'm just sort of looking back during COVID, and what were some very crucial policy changes. Post COVID, we have a lot of understanding of what happened during COVID. Now that we are in the post COVID era, from a policy standpoint, I think what do you think are the most crucial policy changes that we need to consider as we go forward? You spoke about vaccine preparedness, you spoke about many of these things, but I just want to leave the question a lot more open for you to share your thoughts on that.
I think the biggest things to think about, the first one is regulatory processes. Regulators need to prepare for innovation. They don't know today what tomorrow's technologies will be. So they need to make sure that they have line of sight to whatever is going on today that might be a potential technology tomorrow. And in general, regulators in developing countries aren't ready for that because they don't have an expectation that the science within their country will lead to a first in class product, right? So I think making sure that our regulatory systems are really strong and prepared for innovation is very, very important. And I think the government has already begun to think about what might be required for that. Um, the other area that I would think about is being able to share across countries. I know that this is sometimes a touchy topic, but I know that during COVID 19, one of the things that happened was that India was able to support many countries in the region, Nepal, Bhutan, Bangladesh. many kinds of training were offered that had utility for those countries. So, thinking about what we bring in through sharing, what we give out through sharing, I think setting those policies in place ahead of an emergency becomes really important. So I hope that I'm pretty sure that the government will be thinking about those areas because these can be contentious issues, and it's good to have a prepared strategy when you're thinking about these areas.
Understood. And when I reached out to you, you were in Seattle, and you had told me that you had taken up a new role at the Gates Foundation, at the Bill and Melinda Gates Foundation. So can you talk a little bit about your new role at the Bill and Melinda Gates Foundation
Sure. I think before starting on the new role, I should talk about my old role.
at CMC? Yeah,
So
sure.
I
Yeah,
retired. Yes, I retired earlier this year from CMC. When I started my career, I always thought I was going to be retiring at 60 because that was retirement age when I started my career. And even though I did postdoctoral training in the UK and the US, I came back to India because this was where I really wanted to work for my entire career. And when it came to getting to be about 60, I had worked in CMC. I'd been asked by senior leadership within the government to come to THSTI for a while. So I'd gone there and worked in and with the government for a bit, then come back to CMC. I was thinking about what next because I built a succession plan. I was all the research that I had done, I had been training young people all along with the idea that when I retire, no program should stop. If anything, programs should expand so that young people follow what I was doing, but also develop their own areas. I was really successful at that, which essentially meant that in CMC I had no role to play anymore. So it was appropriate to think about moving on. And at that time, I considered what I wanted to do. I actually got offered a lot of positions to head institutes of global health in other parts of the world. And I thought if I'm going to be teaching and training, then I can do that in India if I can find an appropriate role in the private sector, right? But then I got offered this opportunity at the Gates Foundation, essentially working on areas that I have worked on, which is enteric infections, but expanding also to looking at diagnostics, at genomics, at modeling. And these are areas where I think there is significant potential for impact in South Asia and in Africa. The division that I'm in, the division of global health, the idea is to try and promote the kinds of innovations, products, strategies that can actually lead to impact for priority diseases. And enterics is something that I have a strong technical background in as a clinical microbiologist. I think diagnostics have a humongous role to play in delivering appropriate care to people. So let me stop here and ask you a question. When you go to a doctor and you're seriously ill and the doctor just gives you medicines, do you think they've done a good job by you?
that's a great question. So it depends on how I am as a patient, first and foremost, more than the doctor. I would see that that there are three sort of possibilities to how anybody might treat anything. They can be sort of supportive, they can be progressive, or they can be aggressive, right? In how they choose to tackle the problem. So there can be dissenting diagnoses, but I'd rather get the whole load of data first, then come to a conclusion about it. So when they give me any piece of information, I do take it, I don't question it, but I want to gather my data and then take a decision, because I think it's if it's a health decision that's going to affect me, I want to be in control if it's good, and I want to be in control if it's bad, because it doesn't make sense to blame other
And
people.
you want as much data as possible, right?
Yep. Yep.
So if you have data that just comes from your own history and the doctor treats you based on that, that's not really using all of their, some interpretation, but not all of their expertise.
Hmm.
If they examine you, now you've got some amount of objective information from their examination,
Right.
and you hope that they know how to do a good examination. Then they might order some tests for you, and that creates your whole package, whether it is an x-ray or it is blood tests or urine sample or something like that. So you put together your information that's come from your history, your information that comes from the examination, and you put together your biological information, and that creates your data set for deciding what your next step is.
Exactly.
What
Yeah.
happens in primary care, right? So, what you are satisfied with, and what our expectation is of what people should be satisfied with in primary care, are two different things. So, that's why I'm working on diagnostics.
Absolutely. I mean, it's even more incredible that this is the question you asked me. I will tell it to you post recording if you have a couple of minutes. But I will move to my next question, which is, uh, I want to move more into the public health policy side, which is, my first question is on, how can India's disease surveillance systems be improved in terms of its ability to monitor and respond to threats?
So, I think one of the problems that we have with disease surveillance systems is that there is quite a lot of variability in the data that is captured in different kinds of settings. So, if you want uniform surveillance across the country, you need a uniform protocol that is followed identically everywhere. And actually, we have the integrated disease surveillance program that is coordinated by the National Centers for Disease Control, that is supposed to monitor both infectious and non communicable disease. The problem is that the communicable diseases tend to be monitored best in vertical programs, and variably at any administrative level for anything that is not in a vertical program, unless there is an outbreak. So, if there is an outbreak of fever, of hepatitis, you'll get to know about it. But how many fevers normally occur in that population, you don't know. And what the causes of those fevers are. If it doesn't come to a TB clinic, you will not know. So, I think we do need to strengthen our surveillance programs and monitor them much better than we do at the moment. So, while the framework exists, the implementation can definitely be improved.
Understood. And how should India approach budget allocation to ensure efficiency and equity in healthcare services, in your opinion?
So, I think this is something, the aspiration is to have a certain percentage of our GDP contributed to health. We've never been able to manage that. And a term that I had heard was that seemed really interesting to me was absorptive capacity. Even if we make the full allocation, will it be appropriately utilized? There has to be a gradual progression so that the funding, the resources can be absorbed by the system. And I think one of the things that we could do better is potentially look at the differences between states and see which states are able to implement better, serve their people better, and then see whether we can use those approaches for the states that seem to do less well in utilizing their allocations. This kind of interstate learning, I think, is an opportunity that is sometimes utilized in some areas, but perhaps if it was more systematic, we would be able to get up to using the aspirational budgetary allocation better. And once you get to that point, then you can think about what next.
Understood. And uh, India has a significant percentage of young people in STEM, like science, technology, engineering, math, and medicine. And biology, life sciences is also becoming more and more data oriented, right? How might a few arenas be transformed if our demographic really comes together with better data interpretation and modeling skills, and better understanding of, say, medicine and genomics? Where, because we have a particular perception of medical education, we have a particular perception of how doctors and medical practitioners actually work in India. So when you take a high portion of the population moving into STEM education, marry that with the data orientation that the life sciences are actually going through, how does that actually transform India, in your opinion? What might be some areas to look at?
I think there is no area that does not benefit from better data. So, whether you're talking about image analysis or you're talking about allocation of healthcare personnel to particular facilities depending on the workload that they have, I think data systems need to underpin both efficiency and innovation. We have a lot of wastage within the system, and some of that could be addressed if we were to appropriately collect and use data. And right now, with digital tools, these are incredible opportunities to be able to think about, with a constrained system, how do we use what we've got best? Some of this can also be, you know, in terms of prioritization exercises, what constitutes best value for money? What is going to give us the maximum impact? Frequently, we have programs in place where you're pursuing actually diminishing returns for every last bit of investment that you make. So, if there are trade offs that need to be made, you need to have the data to make those decisions. So I think data science is going to underpin society in the future. It's not just about medicine.
I absolutely understand. And my final question to you, Dr. Khan, thank you so much for joining me on the show. And my last question to you is, what is one piece of advice that somebody gave you that absolutely transformed the way you thought about how to live and how to lead?
The one piece of advice was, what have you got to lose? This was, uh, when I was thinking about making a big decision, it was, what's your worst case scenario? What have you got to lose? Once you've figured that out, it becomes very easy to make a call on whether you're willing to take a risk or not.
Understood. Dr. Khan, thank you so much for taking the time being on the show. I had an absolute I had an absolute blast talking to you. I hope you had a great time talking as well. And thank you so much for being on the show. I deeply appreciate it.
Thanks a lot, Vignesh. It was a pleasure to join you.